Another thing that I really appreciated in your book was describing the difference of taking care of someone as they die in their home versus someone that's dying in a hospital bed. And that's a difference I see a ton now working in the ER. There's such a huge difference working with a dying patient in a hospital bed versus in their home with their family standing around. Can you talk a little bit about kind of that difference and that experience dealing with someone in their own home with their family standing around and kind of why that's different?
Yeah, I mean, I think the number one thing to remember about people doing this job is the majority of them are young, and so you're in your mid to early 20s and you're having to deal with things that emotionally you're probably not really equipped to deal with, loss, trauma, grief, um, the baggage of someone who's sort of, you know, suffering from a long-term illness and what that does to them and how that alienates them and might make them bitter and therefore might make them a difficult patient, which you need to be aware of and sympathetic to. These are all things that like I really feel like when I first started and maybe even toward the end, I mean, God, I was only 32 or 33 when I got out, something like 34 or something like that. Still really young. So much you don't know about the world, but you come into a house and I like everybody else, my deaths ran the gamut. There was a guy I got called in for. In fact, weird thing, we recently moved back to Atlanta, and the house where this happened is within walking distance of my house. It's right around the corner. I pass it every day, and I think about this all the time. But we got called. It was I don't think it came out as an arrest. I think it was like one of those calls that came out. It was like person down, probably 48 kind of call. And so I get there and I just walked through the door and there's a guy who met me and he was like, "Hey, he's back here." And he walked me to the bedroom and I walk in, sure enough, the guy's lying in bed and he's dead. And the person who had guided us back was his partner, probably of like 20 plus years, maybe 30 years. I mean, they were older, they were in their 50s. And he knew this guy was going to die, and the guy did die, and he'd been waiting for it, and it was best case scenario. He died at home in bed, not alone. But now this guy was sitting here with his body and nobody else. And the person that he had spent the last several decades of his life with was gone. And here I am, some 26-year-old, who thinks I'm a badass because I can, you know, shoot you at D50 through an EJ on the side of the highway, or intubate you through your windshield. And I'm sitting at his kitchen table trying to fill out, paperwork because, like all death needs paperwork. And he was like, "Do you want a slice of pie?" And he brings out this lemon meringue pie out of the refrigerator. And I just sort of recognized in the moment that like, oh, this guy needs some time. And I was like, yeah, yeah. So we sat there and he slices up this pie and we eat it. And he brings out a photo album and he's showing me like who this guy was when he was young and sort of what he did professionally and what his life looked like and what their lives looked like. And onset in all this was like, hey, this part of my life is over. Like I am no longer the person who lived this photo album. I'm now someone who's all by himself. And that was just a guy not even coming like this was a long coming illness. So he'd been thinking about this and he'd been living with, the pending absence of this person. But this was his first, like the first thing he did alone was like, hey, let me take a minute to relive who this guy was and who we were. And, it was almost like saying goodbye to what he'd been. So there are those moments. And then, there are the panicky moments where everything's going 1,000 miles an hour and you don't even need a brain for that. You just need the muscle memory to work the arrest. But, those ones where, you work it and you call it and you have to walk into the next room and the family is hopeful, they've heard the CPR, they've heard your monitor, doing its whole pre-shock thing. And, the BVM burping as you're doing compressions and all the noise and the firefighters coming and going. And then everything stops and you have to walk in there and look these people in the eye and say, very clearly. And I learned that early, like you cannot mince words, because if you give them the slightest bit of hope, they'll assume like, oh, there's a chance. So you have to say like, I'm sorry, but he's dead. And then begin immediately to say, is there somebody we can call? Like, who is your funeral home? What are you going to do from here? Is there somebody that can be with you? And it's really intimate. It's just you and this person, and they're going through this horrible moment. And you've got to navigate that, and there's no training for that. There's nobody ever says to you like, hey, you really got to be sensitive because someone's going through the worst moment in their life. And this really deep thing that's happening, like the person they love most has just died, and they've died in your hands. And it's not your fault, and you're not going to be blamed, but you're now a part of that death. And you're also a part of whatever comes next, like the grieving and the healing and the moving on and all those things. Like you're the first step in that chain. And it happens in the very room where that person lived. They're not at a remove. It's not in some hospital, in some ER, the family room where they let people grieve while you're working CPR and inside the ER. Like it happens right where that person lived. And it's just, I don't know, man, it's heavy and it needs to be handled properly. And I just don't think we don't have the training for it. We don't. Then it's a really difficult thing to do. I always considered it kind of an honor. It's a weird thing to say, but I took that responsibility seriously. And I don't know how else to do it, because it's just so, such a weighty thing.
Yeah, that's really well put. I like the word intimate about it too, because in the ER, we deal with death on a regular basis as well, but there's so much staff there and so many resources there. There's chaplains coming and going. There's a room to put the family in nearby. We can let them come in and watch and then usher them to another room. And there's other people to do so many of these different roles, whereas when you're in their house and it's just you and your partner, you are doing all those different roles. And it is a lot harder on you emotionally, I think, just being in their home. And people sharing their photo albums with you. That's a heavy burden to take on that I feel like in EMS, you end up taking on a lot more than we have to in the ER with people dedicated to these roles. Like that's all they do. The chaplains, that's what they do, is deal with these grieving family members. So I think that's a really, really well put way that we have to deal with it in EMS. Kind of shifting gears a little bit, I love that one of your first ride-alongs, the crew felt the need to explain to you first and foremost, like, this is how we fight patients. And I kind of remember that in my early days as well as an EMT. Like, I just remember fighting so many people when I was a brand new EMT, and then even when I was a paramedic, especially working night shift, I felt like we were fighting people all the time, combative head injuries or drunks. And the culture used to be we forced all these people to go to the hospital if they're drunk or if they're suicidal. Like, we're forcing you to go. This is our job, is to force you. And I feel like that culture has shifted a little bit, especially with suicidal patients that are not going to be a harm to anyone else. The cops will not force entry into their home anymore. There's a little bit of a difference. So I feel like, and maybe this is just the fact that I work in the ER now, but I think it's lessened a little bit, the amount of fighting or forcing people to go against their will that we used to do back in the day. Did you observe that in your career at all? Do you feel like the fights that you got in all the time lessened over the years, or was it about the same?
For me, it always sort of remained the same. I found that, fighting was almost 100% avoidable. There are those patients that you don't have any choice, and you're just, you walk in and you're going to have to wrestle them down and sedate them, and, whether they're drugged out or whatever, or you get the occasional really pissed off family member who, when you walk through the door, you're the problem. And there's no amount of apologizing that's going to get it done. And so the whole, the situation sort of just never gets in hand. We all have those with dangerous bystanders and stuff, but I found so much of it, came down to relationships and how you dealt with people. It's important to know that a cop walks into a scene with a bulletproof vest and a stick and mace and a gun and the authority that comes with being a police officer. And on an ambulance, like, you don't even have authority. Like, people understand, like, hey, you're only here because we're allowing you to be here, and you're certainly unprotected, and you're not really trained in any kind of like, you know, self-defense. So like we can do whatever we want to you, and you're operating on their goodwill. And it it it's a good thing to remember that, like, you know, how you approach people, how you treat them is so incredibly important, because really, you know, I mean, yeah, ultimately the job is public safety, and there are some people who are really difficult and really impossible. Um, but it is medicine, it is caring for people, and you know, that should be how you approach it, regardless of where the patient is, or the condition of the patient, or who the patient is. And you know, I looked at, over time, I looked at like, who are the people who very quickly get wrestled to the ground, and who are the people that don't. And so much of it has to do with like, do I think this person has the means, you know, to demand respect, to demand that I get in trouble for being a jerk? And you know, a lot of people would walk through the door and just be a complete ass. Either they were an ass with everybody, or they were like, oh, we can just be an ass with this person. Um, you know, like, and so that was a big part of it, was, you know, those two guys that I worked with early on, like they were of an earlier generation of medics, you know, who they came up in the 90s when the city was much more dangerous than it was, and Grady was a lot more informal than it eventually became. And you know, they could get away with a lot of stuff that you couldn't later. And I can't imagine what it must be like with cell phones, you know. But you know, so many of the fights that take place on scene probably would never take place on scene if your medical director was standing there, because your approach would be different. But you know, yeah, it's it didn't change for me. The number of difficult people remained, you know, and those dangerous situations. In fact, that was part of it. You know, at some point, like, I'm in my mid-30s thinking, so how old do I want to be wrestling somebody on, you know, Thanksgiving morning, you know, behind a warehouse? Uh, you know, like, how old do I want to be when I'm doing that? You know, the answer for me was like, not all that old.
Yeah, I kind of thought the same thing. Even when I was in paramedic school, I knew what the job was, you know, having worked as a full-time EMT for a couple of years. And I was like, do I want to be doing this when I'm 65? And the answer was no. And that's kind of when I started the process of PA school and all that as well. I like your point early in your career about kind of lacking this sense of professionalism and being more tourist than being dedicated to like learning the medicine. I think a lot of us feel that early in our careers. And then you talked about a partner you had that kind of renewed your passion for EMS and how he made you a true believer. The partners we have make such a huge impact on us. You know, we work with them every day for hours and hours. We get to know them personally, and how they treat patients often will rub off on us as well, for better or for worse. Can you talk a little bit about the partner that you had that kind of changed your perspective on the job?
Yeah. He actually died a couple years ago, tail end of COVID. But you know, he was one of those guys. We all have those people that, you know, he knew from an early age that he wanted to be on an ambulance. Um, got into the work right out of high school, started out as a volunteer, and then, you know, eventually made his way into paid service. But he, you know, for him, like, there was he had talked about running this call, and he was like intubating someone on the highway. It was a rollover wreck, patient had been ejected. And he was like, you know, as I was intubating, I looked to the left and I could see the grooves on the highway. And he was like, oh my God, this is the coolest job ever. And he just never lost that excitement. And my very first partner, you know, was like, he was a handful, man. And he was that guy that was always looking to get the refusal. I mean, I remember he and I ran a call at a bar late at night. Woman had been stabbed in the neck with a bottle. It was like, you know, not like knife stab, but like mangly broken glass hamburger kind of looking thing. And he like fully worked that refusal. And I remember standing there thinking, like, there's no way that we're supposed to be doing this. And that was who I was with for, you know, I don't know, however many months. And you begin to think like, well, maybe this is how it's done. Maybe this is the way the job is supposed to be done. And I was lucky that early enough in my tenure, someone came along who was like, no, you should wake up every day and just be excited to be here, and be eager to learn the medicine and to practice the medicine, because look what you get to do. Like, look at this thing you get to do. You get to take this person who's, standing on his couch because he's so deep into an asthma attack that he can't even, like, like he's kind of beginning to lose it. And he's literally standing on the furniture and, the can't breathe more than once or twice, or can't say more than one or two words without a breath. And, all the things that you note from like a severe asthma attack. And he's like, and within 5 minutes, you can bring that person way down. There are all these different things that you can recognize and you can treat, and you can then sit down with the doctor and have a conversation about why this or this or this happened, or why this didn't happen. And how incredibly cool is it that we get to learn all this and be a part of this. And it really, that was important. That was, a beginning of a shift. At least in me, I entered into it, like I said before, this idea of like, I wanted to get in touch with some sort of mystical force in the universe that I felt like people who did this job were in touch with. And then you begin to realize like, no, it's not mystical. It's like, it is the practical application of medicine. It's caring. It's caring about how good a job you do. And it's caring about the person who has trusted you to walk through their door in their moment. And, he really was the one who sort of pointed that out, that, this is blue collar medicine. Like, there's so many things in medicine that make it impersonal. All those things are absent here. It's just you and another human being, and you have so few tools at your disposal. I mean, literally, like, I wrote it in a book, but I wasn't kidding. Like, when you walk into these calls, I mean, this, it's like, you armed with like a pen, a wristwatch, a stethoscope. Like, those are the things that are immediately within your reach. And your common sense. Like, does this person need what they seem to need? Is their situation as bad as they're claiming? Is it worse than they're claiming? Do I need to slow this down? Because if you go running in the door, let me tell you, any new paramedics out there, if you go running through the door with every patient that you pick up saying, oh my God, oh my God, oh my God, within a week, the hospital is going to sniff you out. And they're going to say, when this guy calls, do not give him orders because he has no idea what he's doing. So you've got to know, like, that index of suspicion, which of these people are for real and which ones are not, and who do I need to treat quickly, and who can I sort of bring to the hospital but keep an eye on, because those can trick you too. The ones that you're like, no, I don't feel anything right yet. And then you get halfway there, and all of a sudden, like, this friend of mine had this great call that he ran early on in his career, domestic dispute. There was like a picture hanging hammer or something, like a teeny tiny hammer, a couple ounce hammer that got thrown across. No, it was a plate. A little decorative plate got thrown across the room, hit his patient smack dab in the middle of the forehead. He did not, he was like, look, this is a domestic dispute. The guy got hit with a tiny little like saucer plate. I'm not going to mess around. His partner jumped out of the ambulance and like put a hand on that person's forehead. And he noticed that when he pressed on the guy's forehead, my friend noticed that the guy had postured, and he was like, whoa, like just for just a second, he kind of like, and so he puts him in the ambulance, and he's kind of like trying to look at him. He's like, did I see what I think I just saw? So, we all know that feeling of like when you take something casually and you have that like that fear of like, whoa, have I missed something? And so he gets him into the ambulance, and by the time they get to the hospital, the guy was intubated. Like, because that weird, like, just a bad piece of luck, that little plate that hit him in the forehead somehow cracked his forehead, and he wound up with a bleed. And had his partner not jumped out and said, I'm going to put a Band-Aid on that little nick where the plate hit, that guy dies. They immediately look at his refusal, like, boom, he's fired. He's long gone. So you never quite know, but you do need that index of suspicion, which comes up with time. And it's just, it's the experience and just being around and being focused and paying attention to your job and learning it, and appreciating this like incredible opportunity that you have to be there.
Yeah, that's a great point. You talk a little bit about a brief stint of being a Paragod, which I think a lot of us are very familiar with, and a lot of us went through ourselves. Hopefully that stint doesn't last too long as a Paragod, but can you expound a little bit on your time as an invincible, infallible paramedic and how that was brought to an end?
Yeah, well, it happened. It started like everybody's happens. You work the first few months and you're terrified. It's funny. You when you're an EMT, you're like praying for carnage. You just want, like, I remember I was on an ambulance and I was an EMT and the medic was driving and a motorcycle flew by us at 1,000 miles an hour and then jumped on the brakes because he almost hit the car in front of him. And when it happened, I was like, hit him, hit him. And the paramedic was like, you dick, and he had been around long enough that he was probably just looking at it as a lot of paperwork. He was definitely not worried about having to treat that patient. But that's the difference between the two people. So when you become that new medic, you don't want it to happen because there's so many doubts that you have in your mind. I don't care how good your school is. I never knew anybody who came out of school and was like, I'm ready for everything, who wasn't already a Paragod. And so, you go through this first few months, you're uncertain, you run a couple calls, you realize like, no, actually, I can do this. I feel good. And then, what's that phrase? Uh, hubris comes before the fall. That's kind of what begins to happen. And so you get a little overconfident and you think like, hell yeah, man, I got this. Like I'm in control. I'm doing my thing. Paramedic patch on my arm, like I'm ready to roll. When you roll up on scene, as people turn to you and, hey, what do you want to do? And everybody's like, hey, what do you want to do? What do you want to do? The doctor's like, hey, let me question, what drug did you give him? Oh, that's interesting. Okay, hey, maybe next time try this. Or, when you're having these conversations, you're thinking, damn, like I'm in it, man. I'm doing it. And it's that overconfidence that comes from not knowing all that you don't know. Like there's almost nothing worse than someone with a little bit of experience because they think they got it and they don't yet realize all the things they don't know. And for me, it was a couple different things happened, but one really embarrassing one, but it's just flat out truth. Caught an arrest, and it was like this abandoned building, so it was really dark. We couldn't see anything, and we get through the door, and we hook him up, and there was like interference on the line. It looked like maybe it was fine VFib. I don't know. We shocked it. We're doing CPR. It's super dark, and I was like, hey, let's just get him in an ambulance. Like I'm not going to tube him in this building. There's no light in here. We get him outside. We're in the ambulance, and then of course we're like 2 minutes from the hospital, super, super close. So I called the hospital. I was like, hey, here's my report. We're going to be with you in 2 seconds, but here's the report. And we come rolling in. And only now have I started to look at my patient. And as I am, and this is like we're rolling the stretcher through the doors of the ER. And as I'm beginning to look at the patient for the first time, I hear somebody say, I thought Grady was supposed to be good. And I look down and the guy's got he's got like lividity, all like you can see it. And I was so like cavalier and just like it was like our third or fourth arrest in 2 or 3 days. So, we're churning them out and they were all going so well and everything was going perfectly. And the guy was like purple from the third half down. And it, like so he'd been down for a while and it's too late. I'm rolling into the CPR room and I'm like, oh my God. And we start to move him over and the doctor was like, whoa, whoa, whoa. And he was so pissed. I can't remember everything he said, but rightfully, he was belittling and angry and just jumped all over me again, as he should have been. And so I just had to walk out and I had to write up my report. And he was like, I'll sign that thing. But Jesus Christ, man. And so I'm sitting in the crew room and this nurse that I knew walked in and she was like, it happens. Like, what are you going to do? Like, just shake it off, do your thing and then go. But whatever, like learn from it, but it happens. And, those humbling experiences begin to mount up. And also, there are people who, as an EMT or whatever, that I might have thought like, oh, I don't know if this person's a very good medic. Once you are a medic, you begin to look at them a little bit differently and you understand their decision-making more and you see things from their perspective. It's kind of like when you're a kid, you suddenly become a parent. So you begin to understand your parents a little. The shoe's on the other foot. And I was like, oh, wait a minute. Like this person who I thought was maybe a slacker, they're actually not. Like she just really knows what she's doing and she's not going to be fooled into getting overly excited about something that she knows is either not real or that she can handle. And, beginning to see that better and more clearly and see people in a new light, see myself and my own limitations in a new light, and realize like, oh, there are a lot of people who can be of help here if I just stop being, an ass and listen. And it's just growth. I'm sure every field has that. When you're young, uh, you think you've got the world by the tail, and then, experience sort of snaps you, and hopefully you learn from your mistakes and you begin to realize like, oh man, these people around me, they've been exactly where I've been, and they're 10 years, 15 years ahead of me now. Maybe I can learn something from them.
Yeah, I think that's a great point. I think after you do gain some experience, you start to realize you're not infallible, and you can learn from people that are, maybe perceived as lower than you on the, medical hierarchy, or even those above you. You start to realize, oh, I should be actually taking advice from people. Other people like have very meaningful contributions. It's like the whole not listening to your EMT as a paramedic. It's like they're looking at it from a totally different perspective, and maybe they're seeing something you're not seeing on this scene, and you're an idiot if you don't listen to your EMTs. I think that's a great point. You talk about in the book kind of the process going from full-time in EMS to part-time to ultimately retiring from EMS. And I had a similar transition, which in a lot of ways helped me kind of get out of the field. I think before burnout really took its, complete toll on me. And a lot of people kind of, I think, find themselves in a similar scenario in EMS where you put a decade into this, and then a lot of us kind of end up moving on, whether it's to nursing school or a different career altogether. It's more the exception that we see these paramedics that stay in the field their whole career. They're out there. I've talked to a lot of them, but they're more the exception than the rule. Why do you think this is, and why did you ultimately kind of end up moving on?
I think the problem is there's nowhere to go. I had a number of times people said, hey, why don't you go for supervisor? And, like, you know what a supervisor does. You've been around on an ambulance. They all day long, they're waiting for their phone to ring because they know 4 or 5 people are going to call out. And then for each person who calls out, they're going to have to, because we've all also had our phone ring from the supervisor on our day off, which you do not answer that phone unless you're ready to go in because you know what the call is. So that's what you spend half your day doing. The other half is chasing up people who are doing what they're not supposed to be doing and are getting in trouble. Or someone has a fender bender and you got to run them through the whole P-test thing. And then maybe every once in a while, between that, coming up with shifts, making sure all the trucks are staffed, dealing with whatever, disciplinary issues need to be dealt with. Maybe once a shift you get out. But I knew people that you almost never saw on the streets. And so I thought, well, that's really not the job I signed on to do. Like if I want an office job, I will move to a field that pays better, and do an office job. I could have, you could, and there are great supervisors out there. I had some really, really good supervisors. So there are people but that's what they want to do and that's what they should do. It just wasn't what I wanted to do. And, but that's the next move. Or you go inside of a hospital and, it worked for you. You saw it as a path. I looked at the hospital at the time and I remember just thinking like, it's so far from what I've done or from what drew me into this. Like, I don't even know who I am as a provider in a hospital setting, because Grady's hospital based. We used to be able to, if you want, you could pick up an overtime shift in the ER. And they did pod nursing at that time. So you would just pick up a shift and you would get associated to a pod. And it would be, I don't know, let's say there's 4 nurses and a couple of phlebotomists and some techs. And, you'd go in and work as a tech. And, it was cool. You get a lunch break and things are a little bit slower and you can talk to everybody and kind of run your mouth off. And, it's funny and it doesn't rain on you. But it was a completely different kind of medicine. It was a completely different job. And I was like, man, so that's not what I'm going to do. What am I going to do? Like, how long do I do this one particular thing? And I just, at that time, I just didn't see other types of medicine as where I would go because, I mean, the autonomy you have as a paramedic, it's really incredible. The things that you're allowed to do, really only a doctor is allowed to do. And not to say, and I've said that before, and, I'm always quick to say I'm not in any way, comparing a doctor to a paramedic in terms of like knowledge or scope or anything like that. But in terms of autonomy, yeah, that's like, I don't know where else you go and to get that kind of thing where you can just do anything you want of all kinds of treatments, the full gamut of stuff that you can do without having to ask anybody whether or not you're allowed to do it. And so then you get back to all the other questions we've talked about. How long do I want to be, parked on the side of a street somewhere? Because we didn't have stations, which, I was never down for the station thing. You go into a fire station, it was like there's daytime television on and it smells like yesterday's dinner. And I was like, man, this isn't really my thing. But how long do you want to be sitting in a truck? How long do you want to be getting rained on? How long do you want to be fighting patients? How long do you want to be, I think the most I ever made was maybe $21 an hour. It's like, how long do you want to be making $21 an hour for? Like, there's just a lot of things and not a lot of growth. And it's too bad because there's definitely a brain drain in EMS. I talked to a friend of mine is dating a nurse practitioner who's in Jackson, Wyoming. And she is always blown away by how much he knows. She's like, you know more than the nurses at my facility. And again, like I'm not dogging nurses. There's some incredible nurses and, they're like really good. Their knowledge base is really wide, but so is a paramedics. And I think if you've not worked among them, you might not know that. You might not suspect that. But her sitting down talking to her boyfriend, she's like, damn, how do you know so much? Like, what is all like, how do you get all this? And he's like, well, like that's how it is on an ambulance. Like it's very much a self-learning, self-taught thing because you've got to be able to understand all the stuff that's going on. And yet there's no like there's no step up. There's no obvious next move. And so when you put all those things together, that was really what it was for me. And I suspect that's what it is for a lot of people. And I think it's really difficult. I was for a long time, and I was trying to get this story together. The magazine that was gonna write it for wound up folding, so it's kind of died on the vine. But it was about these firefighters in California. California is an interesting place for fire because there's so many different services. You've got like small city, you've got big county. I mean, LA County is the biggest county in America, and then you also have Cal Fire, which is this big state organization, and they do a lot of wildfire because so much of California is like wild open space, and they do a ton of wildfire and stuff like that. And there are guys who work in various municipalities, and of course some of them get killed, and there's a lot of PTSD, there's a lot of issues. Suicide has become a problem, and the problem that these guys have is like, I know this job is doing me damage. I know that staying here is not good for me. I know that there's a chance it could kill me. I know there's a chance that I could kill myself. But if I leave, who am I? Because I derive all of my value as a human being from the fact that I'm a firefighter. And I really empathize with that because I, for a decade, gained all of my value, all of my self-worth was derived from the fact that I was a paramedic, and that I was a good paramedic. That like if you showed up in the morning and someone said, and you said, who am I working with? And they said Hazzard, you'd be like, oh, all right, cool. You knew I wasn't going to be a dick on the ambulance, and you knew that I was going to be able to handle my own when a bad call dropped. That was to me like that's what I wanted more than anything, was for my partners to respect and trust me. And when you have that, the pride that I got from that was tremendous, and that was who I was. I was a Grady medic. So to walk away from that, I mean, that was a huge part of why I wound up writing Strangers, because like at some point you've got to kind of sit down and like figure out like who am I now? But I don't know who I am now if I can't figure out what those last 10 years meant. So I think I really need to figure out what those last 10 years really meant and what they taught me and what they say about the world, what they say about me. And so that makes it really hard to walk away because people know you, this, people know you as a PA, they know you as all these different things, but for a while they knew you as a medic, like, but they know you as a medical person, like that. There's like trust that is conferred upon you and respect that is conferred upon you. And people look at you a certain way. And then so to suddenly like have that taken away from you or to shed it yourself, that's a scary proposition, man.
Mm-hmm. Yeah, that maybe is why a lot of them end up staying, without knowing where to go from there. It's too bad there's not a progression really from paramedic. I mean, a lot of people say PA is kind of the next step, and I wish that there was a faster PA program for paramedics, because there truly are a lot of topics in PA school that really could be covered much quicker knowing that you're working with all paramedics. I mean, there's a lot of cardiology topics and 12-lead interpretation that could be totally skipped if you know what knowledge base you're working with. But to my knowledge, there's not really any programs that are that specific. And they have to teach you about all the other different realms of medicine, all the non-emergent stuff you're going to see if you're working as a primary care PA. And so they have to catch you up on all this other non-emergent stuff. And if you're going to be an ER PA, I think the paramedics are a great foundation to jump into that career from. Because most of us that were, there's a handful of us that were paramedics before, and we know we wanted to stay in the ER, but some people go on to other specialties, and I think that's why there's not faster programs. They have to start kind of from this different foundation and teach you about all this other non-emergent stuff you might be treating. And but yeah, it's hard, I guess, to progress from paramedic. I mean, I guess a lot of people go on to supervisor, and like you said, that was never a job I wanted to do either. And for a couple dollars more an hour, getting crews in trouble and testing their urine when they wreck the ambulance. And yeah, it never sounded appealing.